a manipulated joint. The problem with this study is, and I think the reason it's never been reproduced, is in order to take an MRI image like this, you need to hold for 5 seconds. And the property of the tissues under your hand with a 5-second hold is nothing like the property of the tissues under your hand with a 200 millisecond thrust, right? And so the generalizability of this is negligible, right? So it's an interesting exercise, but it really doesn't inform us as much. On the other hand, this is a review done on the effects of biomechanic parameters of spinal manipulation by a chiropractic, Giles Geyer, who I don't know, wasn't familiar with until I prepared for this lecture today. And he basically, and I agree with this very much, it looked at preload force, peak force, thrust duration, rate of force application, contact site, and individual variability of tissue extensibility. I love this. This is kind of what I've been teaching for years, and the way that he put this together, I think, is really useful, right? As a matter of fact, at some point, Rami and I did a study using this articulated total body that we got from an engineer we know, an engineer in orthopedic surgery. I got it from the Defense Department. It was used to measure forces during airplane ejections, and we tried to use it as application for joint manipulation. And it had a database of like 17,000 bodies entered into it, body types and so forth, to see in this modeling kind of what happens under your hand based on the speed at which you manipulate, or if you rotate the limb slightly and so forth. And unfortunately, we never moved forward with it. It was presented at the Society of Automotive Engineers. And I never found another engineer other than Rami to do the mathematics and grunt work. And so it just lay there. I ran to Tom the other day and he was like, we should have done something like that. I said, I know, if only Rami. But those are if you think about preload force, it's the force you apply when you touch the tissue. Peak force will be the peak force of the thrust, right? Which will be seen right here. The thrust duration is the time that you're thrusting, the duration of the thrust. Rate of force application, right? How quickly are you mounting the force? And the contact site's kind of obvious. And I think this is not to be ignored, right? You can't approach every tissue as if the person you're manipulating is the same as the last person you manipulated, right? Someone may have a different collagen arrangement. They may be slightly hypermobile. They may have tissue damage. They may have a thicker body type. There are so many variabilities here that if you put the same force into every patient you work, it's like giving, you know, an 80-pound individual the same amount of medication as a 240-pound individual. It just doesn't make sense necessarily in terms of how you metabolize it. So this was a study in BMC, an interesting study where they put surface electrodes here on the thoracic spine, the rectangular electrodes, and then they used this machine, which had a very specific rate of application to apply force across the transverse processes of the thoracic spine and see what happened in terms of A, muscle activity, so the surface EMGs, and B, the displacement of the vertebra. And this is basically what they found. And this is somewhat enlightening. The pale bars are the amount of muscle activity that you see, and the blue bars are the amount of displacement of the vertebra. And the reason I put this in is I wanted to bring out a point which is kind of shown here, but takes a deeper look into it. And that is the way viscoelastic tissues behave, like the human body, is a rapid force encounters more resistance, right? So if I apply a rapid thrust, I'm going to encounter more stiffness. It's just the nature of it. On the other hand, a slow force causes more tissue deformation, right? What I sometimes will say to patients, if I take a rubber band and pull it apart, it springs back. If I pull it apart and put 2 pins in and come back in 40 minutes, what's happened is undergone a deformation. So if you want to take care of a patient's contracture, right? For the most part, a dynasplint's the way to go, right? Because you're trying to change the arrangement of the sarcomeres. On the other hand, if you want to break a discrete adhesion, maybe you want to encounter tissue stiffness, right? And you want to break an adhesion. If you want to see a large area of soft tissue respond to a manipulation, right? Then maybe you want to go slow. If you want it more discrete and specific, maybe you want more stiffness in the surrounding areas. And so I think these are parameters that for some reason when we teach manipulation, we don't necessarily teach. I'm not quite sure why. We just teach, oh, this person taught this and this person taught that, and this is cool and this works, right? And I think we also, in that way, we missed the boat. flex the hip to 90 degrees and you're going to get and do a posterior anterior mobilization or manipulation, and you're going to get stretching of the posterior capsule. Really? You might be banging against the back of the acetabulum. Who's done the study? Right? I mean, we just kind of, so they have more hip flexion for a moment, but maybe just contributed to, quicker wear down of the acetabular cartilage. Right? And why do we say that? Because someone taught it once. Right? There's no research to support it. And so I do think we have to hold ourselves. I've spent a lot of my career working and speaking and teaching amongst physicians, right? And when they call me on stuff, I have to own up to it. I call them on stuff too, some of the surgical stuff today, right? 8 years out, you can tell the difference between the two patient caseloads and how much suffering was there in the 8 years or how much benefit. I don't know if you heard that from one of the lectures today. Friar Amir said 2 years out, you can identify the patient who had surgery, a discectomy, a laminectomy, and discectomy from the patient who didn't have laminectomy and discectomy, who had a herniated disc with ridiculous symptoms. So I feel free to call them out, but then I really need to be able to be called out. And I recognize where we don't have some of the information we should. So